Hi, I'm Andrew Curley with the American Hip Institute. Today I'm going to be talking about whether hip preservation with modern techniques alters the natural history of patients with CAM type FAI. Disclosures are on the AOS website. So surgical treatment with modern techniques for CAM type FAI often includes two main aspects to consider. There's the offending agent or the CAM deformity itself, and then there's the secondary damage that results from the CAM deformity, such as labral tears and chondral lesions. Treatment for the offending agent includes a femoral plasti, whereas treatment for the secondary damage involves labral procedures, cartilage restoration procedures, and orthobiologic adjuncts more recently. Each of these topics could be a talk within themselves. So for the purposes of this talk, I'm going to focus on femoral plasti for CAM deformity, as well as orthobiologic adjuncts that are being used in isolation to treat chondral lesions caused by the CAM deformity. So starting with the femoral plasti, we know that performing a femoral plasti is a delicate balance between an under resection and an over resection. What happens when an under resection is performed during a femoral plasti? This is a question that we attempted to answer at our institution several years ago. Patients in our institution were divided into three groups during a retrospective review, including a control group for patients that did not have a CAM type deformity, a treated group, patients that had a CAM lesion that was adequately resected, and then an untreated group, patients that had an alpha angle greater than 55 after surgery, suggesting an untreated CAM deformity. This study found that there is significantly worse survivorship in the untreated group as seen here. Additionally, the treated group demonstrated similar survivorship to that of the controls. When we evaluated the patient-reported outcomes, we found that the untreated group demonstrated a significantly lower rate of achieving pass for modified Harris hip score, whereas the treated group demonstrated a similar rate of achieving pass to that of the controls. So the takeaways from this study is that an untreated CAM deformity was associated with lower native hip joint survivability and less successful functional outcomes. In contrast, correcting that CAM deformity may result in an improved natural history for these patients. What about the other side of the coin, an over resection? We attempted to answer this question at our institution as well in another study, this time involving patients that underwent revision hip arthroscopy. In this study, patients were divided into three groups, an under-resected group, a neutral resection group, and an over-resected group. And this was defined by plus or minus 5% of the femoral head diameter. The study found that the over-resected group demonstrated worse modified Harris hip scores, not only at presentation, but also at most recent follow-up. Additionally, the over-resected group demonstrated higher rates of conversion to total hip arthroplasty, which was seen in almost a third of patients. In contrast, the under-resected group, no patients went on to total hip arthroplasty. So the takeaways from this study was that over-resection of the CAM deformity can lead to inferior outcomes and higher rates of conversion to total hip arthroplasty. And anecdotally, this makes sense. We know that during revision hip arthroscopy, an under-resection and an over-resection are not the same. We have a lot more tools in our tool belt to address the additional bone that's left in the under-resected CAM deformity, whereas with modern surgical techniques, we do not have great options to address the bone void that's left by an over-resection. While surgeons may be aware of the importance of achieving an adequate femoroplasty, achieving this in the OR itself is one of the more technically challenging aspects of hip arthroscopy. Our institution has published on our technique for performing a spherical femoroplasty, which, similar to other techniques published in the literature, involves 6 X-ray views that allow us to see from the far anterior to posterior aspects of the head-neck junction, with the ultimate goal of achieving a spherical femoroplasty on all views. So going back to the original question, do modern techniques improve the natural history of patients with CAM type FAI? At our institution, with our experience, our results would suggest that yes, a femoroplasty does improve the natural history of these patients. What about the chondral lesions and orthobiologic adjuncts that are used to address these chondral lesions? Well, the first question that we have to ask ourselves is, how are we defining orthobiologics? There's been several classification systems for PRP as well as cell-based therapies. Additionally, the terminology has been questioned with studies and experts advising that we move away from the term mesenchymal stem cell in lieu of the term cell-based therapy. And furthermore, more recent articles have advocated for a standardized reporting protocol for these orthobiologic studies so that we know exactly what's being used and we can compare these orthobiologics from one study to another. When we reviewed orthobiologics usage in the literature for patients with the primary indication of FAI, and these are studies that use orthobiologics in isolation, so not with a cartilage scaffolding procedure or an autograft or allograft transfer, 11 studies met our inclusion criteria. 3 of these studies involved hyaluronic acid in the non-operative setting. 4 PRP studies were present, with one of these studies predominantly involving patients with chondral injuries, and there are 4 cell-based therapy studies, with 3 of these studies involving patients predominantly with chondral injuries. The one PRP study found that there were similar PROs in similar PROs and subsequent surgeries at 2 years for the PRP group in comparison to the saline group, which suggests that the PRP did not confer any additional benefit in this cohort. Of the 3 chondral injury studies for cell-based therapy, all 3 of these studies demonstrated significantly better PROs at 2-year follow-up for the cell-based therapy group in comparison to their respective control groups. However, once again, it's important to note that all 3 of these studies use different forms of cell-based therapy harvested from different areas with different preparation techniques, as well as different reporting methods. So it's difficult to pull all 3 of these studies into one meta-analysis to come up with a definitive conclusion. So going back to the original question, do modern techniques improve the natural history of patients with CAM-type FAI? For femoral plasti, we said yes, there was evidence to support that it does improve the natural history of these patients. In contrast, for orthobiologics used for the concomitant cartilage injuries, at the current time, there isn't strong evidence to support their usage. There's some promising results from some of the early studies, but we need additional studies prior to making any definitive conclusions. And this may be one of the next frontiers in treatment of patients with CAM-type FAI to improve their outcomes. Thank you for your time.